All right, guys, I had lied to you in the last presentation. This is the longest presentation. I have shortened it. I have removed a bunch of slides, but it's still about 200 slides. So I will get through this as quick as possible and only try and hit the high points. But good luck. Hang in there. I'm letting you know now. Okay. So the reason why this is such a long presentation is because pediatrics are complicated. Young children with medical issues can be more complicated than adults. I mean, it's different. It's a whole other set of skills, a whole other sets of skills, a whole other set of vital signs. Like it is different. So that's why it's so long. Many EMTs have discomfort dealing with pediatric patients. Absolutely, I know I do, especially if it's like a toddler, or like a 2-year-old or something. Yeah, it's I don't have a lot of experience with that, so it is definitely uncomfortable. So if the thought of dealing with an infant in a medical situation is uncomfortable, that's fine. That's totally normal. That makes sense. Okay. You may have more than one patient, so you have to care for the kid and also the parents and vice versa. So just treat everyone in the room. Okay, so basically infancy is that first year of life, toddlers 1 to 3 years, preschool 3 to 6, school age 6 to 12, adolescents 12 to 18. So those are the age ranges in the vocab. We kind of break it down. Okay, so first year of life, that first month is called neonate or newborn, kind of either way. So these guys really just sleep and eat. It's probably the best time in your life. It's too bad we can't remember it. Okay, so they'll have that sucking reflex for feeding. They can get hypothermic super easy. Crying is pretty much all they can do, and believe me, that's a lot of what they do. They cannot really tell the difference between parents and strangers. They don't really have that figured out yet. But basically, though, they need to be warm, dry, and fed. But their hearing is well developed, so they will definitely hear anything you do. So be careful about that. At this point, 2 to 6 months, a little more active. There's more time awake. They start recognizing caregivers. They may follow objects with their eyes. So they begin to roll over, and so if you're seeing persistent crying, irritability, or lack of eye contact, that can be an indicator of serious illness, depressed mental status, delay in development, something like that. Because at 6 months, those things shouldn't be happening as much. All right, 6 to 12, they're going to start talking. They're going to start sit up, the whole walking thing. So they're getting through it. Then by 6 to 12 months, they're teething. Once again, persistent crying or irritability can be symptoms of some sort of serious illness. And they will, at this point, they're going to want to be with mom and dad. Okay, so if you have to transport them in the ambulance, take mom and dad with you. Okay, and because of that, observe infant from a distance. Don't necessarily just jump in there right away, head to toe, start doing stuff because that scares them. Sensory comfort. So believe it or not, the ends of stethoscopes can actually get pretty cold. So try to warm them up. Make sure your hands aren't cold. All those things do make a difference dealing with infants. Toddlers, a little bit older, this is when they're experiencing rapid changes in growth and development. By 12 to 18 months, this is where they can start to get themselves in trouble because they can open doors and drawers and boxes, bottles. They can start eating stuff they're not supposed to. So this age group is a little bit higher risk. And that's what we're just talking about right there. Okay, so 18 to 24 months or 2 years, this is where their mind really starts to work. They start to understand cause and effect. Their balance and gait improve a bunch, so they can actually start moving away a lot, or like moving away, running. I've seen a few parents have to chase their kids down to the grocery store kind of thing, but that can get them in trouble. And they're going to cling to parents or some sort of blanket or something comfort. But yeah, they may have all of these things, and that's why toddlers are tricky to deal with. Preschool age 3 to 6. They start to use simple language pretty effectively. You can communicate it with them. They're starting to get those motor patterns down, throwing, catching, run, stuff like that. They're learning which behaviors are appropriate and which are inappropriate, mostly thanks to school. Try to get a lot of your history from the caregiver. There's not a ton that the child is going to be able to tell you. Never lie to the patient. That just sets you up for failure down the road. If you lead them down the wrong path and then change your mind, preschool age children will not like that. Okay, we want to begin assessment at the feet because if we start at the head first, that can freak them out a little too much. So we want to start at the feet up. We want to use bandages to cover the sites of injections or small wounds or something. At that point, it's like a visual comfort thing. And we do want to keep these covered as possible. 6 to 12, a little bit older, they can think in concrete terms. They can respond sensibly to questions. they can start to take care of themselves, they can feed themselves, stuff like that. Okay, so only ask questions that let you control the answer. Would you like me to take the blood pressure on the left or the right arm? Ask questions like that. So that way there's not really a way out for them. They can't really say no. You're giving them the illusion of choice, but at the end of the day, you're still doing what you need. Because, for example, you need to do a blood pressure, right? That needs to happen. And so you can give them a blood pressure cuff. They can touch it. They can, play with your stethoscope, stuff like that. Get them comfortable with the equipment. Okay, 12 to 18, so this is you guys. Personal morals begin to develop, maybe. They can start to discriminate between right and wrong, kinda. And incorporate values into decision making. Doubtful, but that's just, I guess, my own personal belief on this ridiculous age bracket for humans. And they will start to go away from their family and towards friends for they are very concerned about body image and appearance and embarrassment, stuff like that. So you all know this. They often feel indestructible, right? 10-foot tall, bulletproof, jumping off cliffs, doing kind of weird stuff like that, or high risk taking activities is pretty common in this age bracket. I know I did. However, that embarrassment stuff is still a pretty powerful component. So we have to respect the privacy as much as possible. And we also want them to be allowed, to be involved in their own care. So provide choices, talking through it. They'll be able to understand what's going on. And if you can't have an EMT of the same gender, you just remove some of that, some personal issues if it's same gender stuff. Okay, so like I said, risk-taking behaviors are common, and you have to watch out for that. And yeah, I mentioned in the previous lecture, young female patients may be pregnant, and the parents may not know, and the kid does not want the parent to know, so it can get pretty interesting, to say the least. Okay, so there's some anatomical differences we should know. So the pediatric airway is smaller in diameter and shorter in length. That makes sense. Lungs are smaller, heart is higher in the child's chest. Vocal cords are higher, and the neck appears to be non-existent. And that, what we're talking there, is for like intubations and airway issues. So their head's going to be larger and rounder, larger tongue, a floppy epiglottis that can cause some airway issues, less developed rings of cartilage in the trachea, and narrowing funnel-shaped airway. So just be familiar with some of these changes as we go on, just so you keep in mind. So for example, diameter of trachea of an infant is about a drinking straw. That's not very much. So think about how easy that would be to occlude. Okay, children have an oxygen demand twice that of an adult. So just remember that. If you're dealing with a kid, he's using up twice as much oxygen as like an adult. Okay, so definitely have to get oxygen on board even faster with these guys. Breath sounds are heard even easier because they're thinner chest walls. And muscle fatigue from difficulty breathing may actually lead to respiratory failure. The muscles just can't keep it. Okay, so sucks. I'd make this a flashcard or something. Just be kind of generally familiar with this. These numbers really aren't too far off, but you might see this on a test on the National Registry. Something about like which one of these are normal vitals or which one of these is abnormal vitals. So just, unfortunately, just kind of look those over and be familiar with the pediatric respiratory rates. Okay, so in the respiratory stress, the pediatric patient is working harder to breathe and will eventually go into respiratory failure. So, and I'll mention this again, but cardiac failure in children is usually because of respiratory failure. Okay, just think about it. Little kids don't have heart attacks and stuff like that. It's usually the respiratory system fails first, and then everything fails after that. Infants, heart rate is about 120 to 160. We want it in that range. And the kids can compensate pretty well, so at least at first. But then once their body kind of gives up, it gives up. It's done. So be careful. If you catch them when they're healthy, do everything you can to prevent them going down further. Okay, so there we go. Pulse rate. Sorry, another thing you just kind of have to be familiar with. So look at the pediatric respiratory rates and the pediatric pulse rates. So just be familiar with these. Okay, the nervous system for these pediatric patients are not really developed, not well protected. The head is bigger and heavier, so that thing can bang around easier. Just like I said, more oxygen, but it also needs more blood flow, oxygen, and glucose. So that means secondary brain damage from hypotension and hypoxic events is actually, there's a higher risk for that. Spinal cord injuries are less common just because it's like floppier, I suppose. There's more ligaments that can kind of bend, and so you might have some ligamental damage, but spinal cord injuries aren't. Altered mental status is going to result from low blood sugar, hypoxia, seizures, or ingestion of drugs or alcohol that they came across in the house. Okay, abdominal muscles are less developed, so that means there's less protection. Also, just as they're growing, their liver, spleen, and kidneys are proportionally larger and sit a little bit more anterior, and they're closer together. So that just means there's a higher risk for multiple organ injury. Signs and symptoms can be vague for gastrointestinal system issues. May not be able to pinpoint the origin of pain. You may not be able to. And large amount of bleeding may occur in the cavity without signs of shock. So if there's any sort of suspicious vital signs or altered mental status in a pediatric patient, definitely evaluate them as quick as possible. Okay, so those bones of an infant's head are flexible and soft, called fontanelles. And that can be actually a good assessment tool, looking at those fontanelles. Thoracic cage is highly elastic and pliable, right? Everything's not hardened up yet. Okay, the pediatric system has thinner skin, higher ratio of body surface area to body mass, which means they're going to have larger fluid and heat losses, like for hypothermia or dehydration concerns. Thermoregulation is immature, so once again, they're just that much more likely to be in some sort of hypothermic situation. All right, got to look this over, got to know it. Appearance, worker breathing, circulation of skin. Okay, that's the Pediatric Assessment Triangle, or the PAT, right? And these are the things we're going to be evaluating when looking at our pediatric patients. The reason we like it doesn't require equipment. You don't even have to touch the patient, okay? Appearance, worker breathing, circulation. So for appearance, note the level of consciousness, muscle tone, interactiveness. You can kind of remember this. So tickles, it's tone, interactiveness, controllability, look or gaze, speech or cry. So our patients hopefully are within normal limits of that. So if they're 2 years old and they're barely interactive and as you're assessing them, they don't even make eye contact with you, that's kind of an idea that maybe something in the is off. Worker breathing, so may manifest as tachypnea, which is just faster breathing, abnormal airway noises, retractions of intercostal muscles or sternum, and that's suggesting there's some sort of breathing issues. And circulation of the skin, we're looking at the skin color and condition just to see if it's pink, warm, dry, is it cool, clammy, pale, is it gray, what's going on. Cyanosis, of course, is that blue skin. So any sort of abnormal skin condition, we need to evacuate that person. Basically, if it's unstable, assess ABCs, transport. If stable, you can continue with the remainder of the assessment there. But as you do your kind of ABCs initial assessment and your PAT triangle, that is probably the deciding line right there based on your PAT. So these are the hands-on thing, right? With ABCs, disability and exposure. Okay, airway, we want to make sure the airway is open using head tilt, chin lift, or jaw thrust, depending on the mechanism of injury. We want to keep the airway and the head in the sniffing position, which is kind of just elevated up, like the nose is elevated a little bit. And that helps keep the trachea from collapsing, and it also maintains proper alignment of the airway system. So look, listen, feel just like an adult. Place both hands on the chest, and you can really feel for that rise and fall. It's actually easier in my opinion anyways, it's easier to assess breathing on an infant because you can see everything a lot easier. You can put the hand on the chest a lot easier. And so I've had better luck doing that. However, remember, belly breathing in infants is considered adequate, and that's because a lot of their breathing is going to be from the diaphragm. It's because those muscles of the chest aren't developed. So they're definitely diaphragm breathers. All right, worker breathing, here's some signs and symptoms that maybe something is not going right. Accessory muscle use and retractions, kind of the same thing. That just means that like you're going to see the neck muscles and like muscles around the collarbone and everything's like shrink wrapped around the ribs, and you can tell it's just really trying to breathe. Head bobbing, nasal flaring, same idea. The airway's really trying to breathe. Tachypnea or bradyapnea, which just means fast breath rate or slow breath rate. If you have slow respirations, that's usually you're not far off from some sort of cardiac arrest because the body's been compensating, and by the time the breathing rate starts to go down, this kid's out of trouble. So determine if patient has a pulse, is bleeding or in shock. Palpate the brachial or femoral pulse. I would go for brachial. Femoral is going to be hard to do. In even way, and it says right here, children under 1, palpate carotid. I'd agree with that, but generally, I would always stick with the carotid or the brachial. Femoral pulses, even in children, can be kind of hard to find. Okay, check that circulation, and that's a good indicator of hypoxia or dehydration. All right, ABPU, or the Pediatric Glasgow Coma Scale, are good things to use when you're evaluating these patients. So we want to, if we have to expose our patient, that's fine, expose, look at what we have to do what we have to do, but always be covering these patients up, remembering they're at a much higher risk for hypothermia than an average adult. So immediate transport, a significant mechanism of injury, car accident, fell off a ladder or a counter, something like that. History compatible with serious illness. So some of their signs and symptoms are looking something serious meningitis, croup, epiglottitis. We want to take that in. Potentially serious anatomical abnormalities, so just something isn't right. Significant pain or any sort of like altered mental status, level of consciousness issues, we're going to take them to the hospital. And you can also kind of look at those things that matter as well, right? If you've never experienced a pediatric patient at all, maybe you can err on the side of caution and evacuate that patient just because you don't have that much experience. If they're less than 40 pounds, transport in a car seat, it's a lot safer for the kid that way. And you can actually mount the car seat to a stretcher. Okay, try to get all your history from the caregivers. So the questions you want to ask about are the nature of illness, mechanism of injury, the length of sickness or injury, how long has it been going on, key events leading up to the injury, if there's a presence of fever, effects of the illness or injury on behavior and mentation and their activity level, and then recent drinking, eating, and what's their urinary output look like. And usually we can use like wet diapers, like how many wet diapers have you had today? And is that normal, is it abnormal? You can kind of evaluate based on that. And same thing, diaper check, just is there anything different there? Presence of rashes. But then you can use sample. The rest of it, you can just use like an adult level to ask those questions. Full body scan, okay, cool. Remember, for these young kids, we want to start at the feet and go to the head. We don't want to be right in their face right away. However, by school age and adolescence, you can probably head to toe. So this is our trauma patient assessment. It's the same stuff, right? You're going head to toe and you're looking for things that are wrong, right? So inspecting the ears for all these things, the mouth for those, looking at the neck, tracheal deviation, bruising, swelling if they can't move their neck, that could be meningitis. Look in the chest for penetrating trauma, lacerations. Really give it a good palpation. We want to see if there's any pain with any of that. And this is all our typical trauma patient assessment stuff we're doing. Okay. Vital signs. Blood pressure is usually not assessed in patients younger than 3. So we try and look at other things for assessment of perfusion. Okay, so and like speaking of that, assessment of skin is the best indication of pediatric circulatory status. Okay, so it's really we got to look at that skin. Okay, use this formula to determine blood pressure for children ages 1 to 10. 70 plus 2 times the child's age in years is the ideal systolic blood pressure. Okay, you might see this on the National Registry. Okay, you might see this math question. It'll be you have an 8-year-old patient, and he's an 8-year-old patient, and what is his ideal systolic blood pressure? You may have to do that. Okay. Normal vital signs. If, like I said, if you're working and you can't remember it, who cares? Just write it in a little cheat sheet and laminate it. Put it in your pocket. It's a really good way. Just real quick, 2 seconds. Look at it. Okay, that's what I should be at. We've already talked about some of these increased work of breathing mechanisms of why we got to be careful and why that should be a red flag for us that something's wrong. Okay. Respiratory failure, it just reassess that frequently because remember, they compensate, crash. Okay, so we have to be with these guys. Airway obstructions can be somewhat common in this age bracket, in part just because they like to use their mouth to taste things and interact with the world. So kids do get in trouble because they put things in their mouth they're not supposed to, and that can cause an airway obstruction. So we gotta know this coming up. Croup is an infection of the airway below the level of vocal cords, usually viral. Epiglottitis is an infection of the soft tissue above the level of the vocal cords, okay? And epiglottitis would be an inflammation of the epiglottis, all right? So there you go. That's kind of a map of like a diagram of the different locations. So infection should be considered if there's congestion, fever, drooling, cold-like symptoms, and obstruction of the foreign airway may involve upper or lower airway. And that's why we really need to listen to those breath sounds and just the airway. Okay, listen to both sides of the chest. All right. Now, if the kid can cough, if he can move air, cool. Have him cough. That's going to be the best way to clear that obstruction, is the patient themselves coughing. Allow the patient to remain in whatever position is most comfortable. If they need to lean on the left side or something or other to breathe better, and it doesn't, interfere with any sort of other treatment, cool, let them do it. Now, a severe airway obstruction, no sound, no crying, cyanosis, all that stuff, that now you got to take over. So if they're moving air, help them out and tell them to cough. Not moving air, now you're in charge. Head tilt, chin lift. Finger sweep to a visible foreign object. We don't want to do blind finger sweeps, but if you can see a Lego in there or something, you think you can get it out, you can try. All right, cool. So asthma, we've already talked about this in class, so I will go through it relatively fast. I see, like I had asthma as a kid, and I actually kind of grew out of it as an adult. So you will interact with asthmatic children. And remember that's not an issue of air getting in, it's an air that's trapped in the lungs and the air can't escape. All right, so definitely want to give some oxygen right away. That should help them out. And a bronchodilator. So unfortunately, that's if your protocol allows for it. And that is 100% district by district. But a little albuterol inhaler goes a long way. Or you can even do nebulizer, which is just like nebulized albuterol. It's just a little mouthpiece thing. Both those things are great treatments for asthma. They really do work. Now, prolonged asthma attack is a true emergency. And they could potentially have airway or respiratory failure because they've been trying to breathe for so long that eventually the body will just give up. All right, pneumonia, one of the leading causes of death in children. It's just a lung infection. Usually it's a secondary infection of something else. But it can also happen if they're breathing in a bunch of stuff, if they're putting a bunch of stuff in their mouth, it goes in their lungs, they can acquire pneumonia. So usually rapid breathing, the grunting or wheezing sounds, that usually means there's more pressure in the system. And when they're grunting, they're really just trying to clear that air out. Nasopharynx, tachypnea, crackles, hypothermia, unilateral diminished breath sounds, that's all suggestive of pneumonia. Generally for this, we want supportive treatment, so oxygen and evac, basically. Okay, bronchiolitis. This pops up in the news maybe once a year or so. There's some outbreak of RSV somewhere. Well, it's respiratory syncytial virus is the name of what causes the viral illness that causes bronchiolitis. It can live on surfaces for a long time, and it does spread rapidly through schools and care centers. And it's more common in the younger ages. It occurs in the first 2 years of life. For some reason, more common in males and most widespread in winter and early spring. We're looking for dehydration, shortness of breath, and fever. Treatment, really humidified oxygen, and consider ALS backup, evacuate to the hospital. All right, blow-by method. This is not as effective. But there are some children who, especially if they're in some trouble, they will not tolerate a face mask. You put it on their face and they rip it off and they freak out. And for them, it's like the end of the world. Okay, so a blow-by is, what they're suggesting here is you place the airway tube, you can cut it off, then put it in the bottom of a cup, and then hold the cup just kind of like by their face. There's even some models are even like stuffed animals, okay? And that way the oxygen is just kind of diffusing out. And yeah, it's not 100%, but it's better than room air. So if you really need to have oxygen on a kid and he's not allowing it to happen, you can consider this method. And there you go, that's what that looks like. Okay, I already mentioned this, but another key point. Cardiac arrest in pediatric patients is associated with respiratory failure, okay? So normally, respiratory system fails first, then they go into cardiac arrest, right? They don't normally go into cardiac arrest. Okay, shock, even kids can go into shock. So remember from that shock lecture, compensated shock, the body is trying to do what it can to save itself, and decompensated shock, it's more or less just given up, all right? And remember, kids can compensate a lot longer than adults. So that means once kids have gone into the decompensated shock area, that's pretty much it. It's not like a slow decline, it's like a very minimal decline and then dropping off a cliff, all right? That's how kids compensate. Yes, so basically kids can go into shock any way an adult can. Okay, so these are somewhat same, right? Signs of shock in adult, tachycardia, poor capillary refill, mental changes. So some of these things can be the same. Blood pressure is super important. You can either ask the patient or talk to the care provider. Has there been a decrease in urine output? Is there absence of tears? Do we see sunken or depressed fontanelles? So that little soft spot in the skull, are they kind of blown out like they're about to pop, or are they sunken into the brain? What's going on? Those are good things to assess for dehydration. And of course, that level, the changes in behavior are good. So treatment, Pretty much the same as an adult. Control the bleeding, open the airway, keep warm, all that fun stuff. Consider ALS backup as needed. Anaphylactic shock, just like adults, those are the same signs and symptoms, same treatment, cool. Bleeding disorders, hemophilia is a congenital condition in which patients lack normal clotting factors. Normally, it's hereditary and is severe, predominantly found in the male population. Now, normally though, they're going to know this, right? If it's a 6-year-old or something with hemophilia A or something, he's going to know it. The parents are going to know it. It will not surprise. Okay. If there's an abnormal neurological state, you can think about this little acronym here. So things like alcohol, opiates, uremia, trauma, infection. I don't think this will be on the test, but these are a good way to remember some of the potential causes of altered mental status in a pediatric patient. So altered mental status, remember those things, that thing I just showed you. All right, seizures is a disorganized electrical activity in the brain, just like an adult. However, where it's different from an adult, in infants, you may not really see it unless you're looking for it. It may be an abnormal gaze, bicycling and kicking motions, lip smacking, stuff like that. They're not quite as obvious in the pediatric population. Common causes of seizures, of course, one of which is the fever. That's probably the biggest one we're familiar with, right? Febrile seizures, you've heard that before. But all of these can actually lead to seizures in a kid. They're in that postictal state, and generally, especially if it's been a first-time seizure, I would definitely take that kid to the hospital because seizures, especially in that age group, are not good. So we need, even if they've recovered and they're feeling okay, I would still transport them to the hospital. All right, status epilepticus is just basically constant seizures every few minutes, and you do not regain consciousness. That patient does not come back. They have a seizure, pass out, they're still passed out, and then they start seizing again. And that becomes a very serious life-threatening condition. We usually are going to have to take their airway and intubate them and all those things. Okay, this is one, especially if it's a status epilepticus thing, definitely call ALS on for some support or take to the hospital as quick as possible. All right, febrile seizures, we just talked about that. They usually last less than 15 minutes, and there isn't normally a postictal state, not as bad. All right, meningitis. We've already talked about this in class. It's the same for an infant, and their immune system isn't quite as responsive as an adult. So these are some of the bigger risk factors for that. Okay, meningitis. The infants younger than 2 or 3 months can have apnea, cyanosis, fever, a distinct high-pitched cry, or hypothermia. So for some of those things. And the stiff neck, just like an adult, stiff neck is a sign and symptom. And that bulging fontanelle, that little soft spot, is going to be kind of blown up like an air balloon. That's usually the bacteria that causes meningitis. Okay, and those are some of the signs and symptoms. If you see these petechial rashes on the skin, very serious sign, and I would evacuate that patient. Okay, so gastrointestinal emergencies, just real quick. I already talked about that. How many wet diapers? Are they keeping food down? That kind of stuff. Is that normal? Is that a normal bowel habits for your kid? Those kind of things. Ask those questions. Okay. Poisoning, unfortunately, can be common because people don't child-proof their house. And so kid's going through a drawer or something. He sees some pills, puts it in his mouth, doesn't know what it is, and now he's in trouble. And so it doesn't necessarily have to be like meth. It can even be certain vitamins or certain even over-the-counter drugs can really harm a pediatric patient. So be alert for signs of abuse. And then try to get these questions answered if a kid, somehow is exposed to something. Okay, activated charcoal. Remember, not recommended for people who's ingested an acid, alkali, or petroleum product, and not recommended for decreased level of consciousness, right? Because if they can't swallow and they're not really with it, we don't want to be giving them anything in the mouth. Unusual dose for these kids is going to be 1 gram per kilogram of body weight. Okay, dehydration. That occurs when fluid loss is greater than fluid intake, and that's usually just vomiting, diarrhea, stuff like that. And those are the signs and symptoms of the different levels of dehydration. Okay, and that obviously is an abnormal sign, something that kid definitely needs some treatment. Okay, fever management, we just talked about that. It can be caused by infection, status epilepticus, neoplasm, some sort of cancer, or even drug ingestion. Like I said, even over-the-counter medication can be harmful to these kids. So we want to look for these signs and symptoms. Okay, basically I'm going to get through some of these because we've talked about these. For drowning, just like an adult, right? Fast, slow, no pulse, pale cyanotic skin, some sort of airway obstruction. Okay, basically 100% oxygen and get ALS over there. Trauma, #1 killer of children in the U.S. Usually it's falls or abuse. Like I said, they're not that good at walking, so they can fall a lot. All right, let's see here. Sometimes children get injured because they don't have that cause and effect thing. They don't understand, well, if I do this, this might happen. They don't really think that far. Okay. Sport injuries, I'm sure, you've all seen the stories about high school football athlete gets a concussion or something. So that's a very serious issue, especially if it involves the cervical spine. Head injuries, it can be common in children just because their head is larger relatively. Nausea and vomiting are common signs and symptoms of head injuries in children. And we just like an adult, if there's any concern about that, we want to do full spinal immobilizations. Okay, chest injuries, results of blunt trauma. The chest wall flexibility in children can produce a flailed chest. There may be no real obvious signs of external injury, but they could have bad chest injuries. Abdominal injuries are very common in children. Remember, they can compensate for blood loss a lot better than adults. Okay, so this is just, you can zoom if you want, just kind of a comparison between adult and pediatric. So just be familiar with those differences. Burns, remember those differences. They have more surface area relative to total body mass, so that means they're going to have greater fluid loss and heat loss. They do not tolerate burns as well as adults. Okay, same content for adults. They're exposed to burns the same way. Okay, remember, we want to prevent hypothermia as much as possible. Keep an eye on their vital signs, especially in the context of burns, because we might need to bring them back from something. Children have immature bones with active growth centers, and they can break on the ends of the growth plates, and we want to be really careful of that because those bones might not heal correctly, and then you might have some sort of growth going on. Generally, though, extremity injuries in children are managed the same way as adults. Okay, pain management. As an EMT, you're kind of stuck with patient positioning, ice packs, and extremity elevation. But that's kind of why you want that ALS standby to come in and give some drugs if you can. Okay, we will talk about this when we get to our terrorism lecture, but it's just another way to talk about it. Jumpstart triage system. It's a triage system that's meant for younger patients. So younger than 8, weighing less than 100 pounds. Triage system is a system of, if you had 10 patients, you walk in a room, there's just you and you have 10 patients. Well, how do you organize them? Do you just pick one randomly and start going, or how do you organize it? So triage is a way of sorting patients. And they have the START system, the START triage system, and they made the Jumpstart triage system, which is for pediatrics. Okay, so it's normal triage system, it's just meant for kids. And there's green, yellow, red, black. All right, green means minor, not really in need of immediate treatment. I mean, they need treatment, but not necessarily right now. Yellow is going to be delayed treatment. So they're going to be breathing, they're going to have peripheral pulses, and they're going to respond to painful stimuli. So they definitely need to be looked at, but they're not the most serious. Red is that most serious. It's respirations less than 15, greater than 45, apnea responsive to positioning, respiratory failure, breathing without a pulse, inappropriate painful response, all that kind of stuff suggests that we need to work on this kid right now. And black is deceased or expectant to be deceased. Basically, no pulse, unresponsive, those kind of things. We can't spend that much time dealing with it. So if you want to, you can zoom in. That's just how they break it down. That's the little flow chart for the Jumpstart pediatric triage system. Okay, one of the last things we're going to talk about is child abuse and neglect. Very common. I've run into it myself quite a few times. So these are the questions we're going to be asking when we encounter this. Is this injury typical for a child? I know a woman whose child broke both arms in the space of about 6 months, and she was actually reported. But that's fine that she was reported. Granted, it was because of, for real, a legitimate bicycle accident, just had a really clumsy kid. But that's an example of something to investigate. He broke both arms in 6 months, and the hospital crew was a little suspicious. But it ended up all working out fine. But that's just an example of something that's kind of a red flag. Is the caregiver being like a normal, caregiver, or are they acting kind of weird? Is there any evidence of drinking or drugs at the house in the scene? Is it something where, oh, I think my kid broke his ankle last week? That's a red flag. And is there a good relationship between the kid and the parents? Are there multiple injuries at different stages of healing? That's probably one of the biggest ones. Multiple injuries at different stages of healing. That means it's a long-term problem. Unusual marks like bruises or cigarette burns, branding injuries. Yeah, I've also seen like hot water stuff, like scalding in hot bathtubs. It's a pretty interesting choices that these abusive people make. Are there several types of different injuries? Are there any burns? Is there any decreased level of consciousness? Is there any bleeding? What does the home look like, right? You can, not to be super judgmental, but you need to look at that and see, is it a well-maintained home, or is the water shut off and, what's going on? These are a possible thing you can use if you want. You can remember child abuse, and these are the big red flags, right? So if any of these red flags pop up, we're starting to think it might be child abuse. Okay, bruises, we've all seen those. Burns, any sort of burns in a sensitive area, that definitely wouldn't have happened on accident, right? So that's a huge red flag. These are just more red flags. Shaken baby syndrome, basically it is what it sounds like. A caregiver will shake an infant, and it actually does a ton of damage to the brain and the spinal cord. And a lot of times these kids will not recover from this. So, and neglect, of course, you got to keep an eye on neglect, like clothing, right? Is that a clean shirt, or does it look like that kid's been wearing that shirt for 2 weeks? Those are all key factors when deciding if there's any sort of abuse going on. Just be alert for conflicting stories or lack of concern. Those typical red flags. Because we have to report suspected abuse, all right? We have to. A lot of time they have special forms you got to fill out. So we're going to report it and then hand it off, right? We don't do any of the investigation or anything. We just notice some of those red flags and hand it off. Okay, child sexual abuse. So treat bruisers, treat the obvious trauma if you can, if as it presents itself, but we try not to examine genitalia unless there's evidence or bleeding, or if the kid says, oh, this hurts here, that kind of thing. If that has happened, there's some sort of genital trauma or something, and this is even more important for a kid because they may not be able to understand what we're talking about here. Do not let them go to the bathroom, wash, change clothes, do anything. I think an adult can understand why we don't want that, why we want to preserve the crime scene, so to speak, but a pediatric patient may not realize that. And once again, we want to do female on female, male on male, if it's possible. Sudden infant death syndromes, unexplained death after a complete autopsy. They just can't figure it out. Normally, it's for kids under 6 months of age. The risk factors are going to be a young mother, a mother who smoked during pregnancy, or low birth weight. And those are some of the risk factors, but they're still kind of figuring it out. The one thing that has been shown to help is kids who sleep on their back. So that's why there's a saying that says, put your kid back to bed. That has apparently made a difference. So they will be unresponsive. They will be in a lot of trouble, and there's normally not a ton we can do about that, okay? Remember our obvious signs of death, right? Rigor mortis, dependent lividity, those kind of things. That shows that that patient's been dead for a while. Okay, very stressful for you and the family. Use the infant's name, because remember, 24 hours ago, this kid was eating crackers or whatever like that, and now the kid's dead in the bed, right? So it's a big change for this family. So you need to be aware that this is a very traumatic, shocking thing for caregivers. Okay, we want to look at those things when we're assessing the scene. Okay, we are apparent life threat events, right? Though that's kind of some other red flags that we can look for. All right, so death of a child, it does happen. It's very traumatic for the family, but I do not have a lot of experience with dead pediatric patients, but I know people who have, and they say that it's usually the pediatric patients that stick with them the most, even years later. And try to just use died and dead instead of passed away. We do kind of want to, we just want to talk to them straight, acknowledge their feelings, offer their support system within like the churches and even the hospital, offer that care to them. Everyone expresses grief in different ways, so just be comfortable with people doing different things. But like once again, this is a very traumatic for people to go through. So Okay, cool. I beat my time hack of 40 minutes. So sorry guys, I know that's a super long lecture, but pediatrics, there's just a lot to talk about.